Hello. On behalf of Nuelis, it is my pleasure to welcome an international audience to the third webinar in our heart failure practice series entitled Breaking the Cycle of Refractory Heart Failure, a Real-World Analysis. All participants will be in listen-only mode. After the presentation, there will be an opportunity to ask questions which may be submitted through the Q&A panel at the bottom of your screen. Participants are advised that the content of this presentation is being recorded for playback purposes. A replay of the presentation will be available on the Nuelis YouTube channel. Nuelis is honored to host this educational webinar with an esteemed panel of internationally renowned physician experts who will provide valuable, provocative, real-world science-based insights on treating fluid overload in heart failure patients. Now it is my privilege and honor to introduce to you our panelists. First, Dr. Maria Rosa Costanzo, who received her medical degree from the University of Bologna, Italy. She is the medical director of heart failure research at Advocate Heart Institute and medical director of Edward Hospital Center for Advanced Heart Failure in Naperville, Illinois. Dr. Costanzo has led several multi-center randomized controlled trials, including UNLOAD and the AVOID HF study. Her academic interests in which she has published extensively include heart failure and cardiac transplantation. She has served an appointment to the National Heart, Lung, and Blood Institute Advisory Council. She is a consultant for multiple national and international journals and is a current associate editor of the JACC Heart Failure Journal. Dr. Costanzo is an international authority in her field and is regularly invited to speak worldwide on numerous topics related to heart failure and cardiac transplantation. She is joined by Dr. John Jeffries. Dr. Jeffries received his medical degree from the University of Tennessee. He is the J. Michael Sullivan Distinguished Chair in Cardiology and the Director of the Cardiovascular Institute at Methodist University of Tennessee, a professor and chief for the Division of Adult Cardiovascular Disease, professor of Preventive Medicine and Pediatric Cardiology at Le Bonheur Children's Hospital, and a research member at St. Jude's Children's Research Hospital. His academic and clinical interests include heart failure, transplantation, and cardiovascular genetics. Dr. Jeffries sits on numerous scientific journal review boards, has authored a plethora of publications, and is considered an international expert, with his research being presented at countless national and international meetings. Today's webinar will be moderated by Dr. Amir Kazuri. Dr. Kazuri received his medical degree from Tehran University. He is professor of medicine and chief of the Division of Nephrology, Hypertension, and Renal Transplantation at the University of Florida. His main academic interests are in the nephrological aspects of heart failure, cardiorenal syndrome, and fluid management in critically ill patients. Dr. Kazuri has been involved in numerous clinical research projects, including those related to extracorporeal therapies and collaborative approaches to heart failure and cardiorenal syndrome. These projects have resulted in a variety of publications, including articles and books chapters. He is viewed as an international expert in his field and has been frequently invited to lecture at national and international conferences. Thank you all for sharing your important research and expertise with the audience today. Next slide. These are our forward-looking statements and the disclosure slide. Now it is my privilege and pleasure to turn the webinar over to Dr. Kazuri. Thank you.
Thank you, Linda. Good afternoon, everyone. It's my distinct pleasure to be here today and talk about a topic that is so dear to my heart and be joined by two international experts on the same topic. I will have a few words on the importance of congestion in cardiorenal syndrome and heart failure. Next slide, please. So many of us know that the fluid overload and congestion is an integral part of heart failure. More than 80% of the patients that come to the hospital for congestion and have heart failure, they would receive some form of diuretic therapy. And the problem with diuretic therapies is, actually I should say twofold. Number one is that in many cases, and in some studies have been shown to be around 50% of the cases, the decongestion process is not complete. 50% of the patients leave the hospital after an episode of decongestion with less than 2.5 liters of fluid removal, or some of them, nearly 16% of them actually, might gain weight while we are trying to decongest them when they have come for an acute decompensated heart failure. The second problem with diuretics would be the fact that nearly 1/3 to 1/4 of the patients present with some form of renal dysfunction while we are using diuretics for decongestion. I have to say here that the matter of renal dysfunction in acute heart failure is a very complex and multifaceted topic in the scope of, which would not be in the scope of this webinar, but needs a different actually discussion and webinar probably. So several years ago, we realized that what we have been saying for decades, thinking that the arterial underfilling is the only reason why patients with acute heart failure will have renal dysfunction, has been wrong actually. That there is a component of renal congestion or renal venous congestion that has been playing a role all this time when we have been ignoring it. So basically the two mechanisms involved in renal dysfunction for a patient who comes for acute heart failure would be the arterial underfilling, that we can call it also low forward flow, or the other side, the renal venous congestion, that we can call it high backward pressure. So low forward flow and high backward pressure are the two main mechanisms for renal dysfunction in patients with acute heart failure. Again, worsened renal function in some instances has been recognized as being an independent predictor of mortality, especially if it is not associated with complete decongestion. If we can have the next slide. So if we are using diuretics for decongestion, in the majority of our cases, we need to know what are the downside of using them. One of the main issues that any physician who has been working with heart failure patients has noticed is that as you start using diuretics, their efficiency comes down over time. This is really a major issue and probably one of the main contributors to the fact that they are not being decongested completely, a great subset of them. Number two is that, the diuretic response is not always complete, and it might end up giving us renal dysfunction, and it is different from renal, the underfilling of the arterial side. For those of you who have a nephrology background or are interested in the renal physiology, I should remind you that when we are using loop diuretics, the chloride goes up in macula densa and activates the what we call tubuloglomerular feedback, or TGF, which decreases GFR, so bringing down the renal function. The third part that I already mentioned is that many of these patients have a high rate of readmission. Actually, I should say unacceptably high rate of readmission. Nearly 1/4 of the patients will come back within 1 month of discharge. Actually, if you remember it well, heart failure has the highest readmission rate among all medical conditions. Apart from that, there are other aspects of diuretic therapy that I'm not going into it. Electrolyte imbalance and hypokalemia specifically, that is a major risk for these patients, should be in this group. Next slide, please. So now that we know diuretics are far from being an optimal therapeutic strategy for these patients, do we have anything else to offer to these patients? This slide is trying to summarize the mechanisms underlying acute heart failure and renal dysfunction, basically cardiorenal syndrome. On the right side is what I just mentioned about low forward flow, the cardiac output coming down and the consequences of that, including neurohormonal activation, which is a main target of therapy for heart failure. On the left side, what you see is the congestion part of it. The fact that the congestion that will be there not only affects the heart, but also affects the kidney through renal venous congestion. So basically, we should keep in mind, in the past, we thought congestion is a symptom or a sign merely. Now we have changed it. Congestion is a factor. It plays a role that has a bidirectional link with the heart and the kidney. So congestion can worsen heart failure, congestion can worsen kidney dysfunction. In these situations, as you see, if we can use ultrafiltration early on, like when it was supposed to be diuretic use on the right side at the top, this could help just stop the vicious cycle that will start with the use of diuretics. But let's say some people start the diuretics, as many of us do, there is always the opportunity to change the course afterwards when the patient can have venous congestion, and the ultrafiltration will give us a form of biologic holiday. We stop using diuretics with all the effects that they have on the renal tubules and specifically on macula densa. We use ultrafiltration, sparing the kidneys and removing fluid at the same time. This is what basically this diagram is trying to tell us. Next slide, please. So what's the advantage of ultrafiltration to diuretics if we want to use it? There have been several advantages, and we have mentioned this in previous papers. Many of actually some of the papers have been written by the panelists of this session. One of them that might be more important for me, for example, as a nephrologist, is that if you remember, ultrafiltration would be hydrostatic pressure that pushes the serum towards a semi-permeable filter. So on the other side, you will have a lot of sodium that comes out with your ultrafiltrate. Basically, it is close to serum sodium, somewhere around 130 to 140. It has been shown, in contrast, for diuretics, the urine that is made is hypotonic. It is somewhere between 60 to 80 millimole of sodium per liter of urine. And again, I don't want to go to the mechanism. It's beyond the scope of this webinar, but it has something to do with the medulla, because when you use loop diuretics, the medulla that is normally very hypertonic, that helps with concentration of the urine in the collecting duct, then it will be dilute. So basically, there will be more water going out than the sodium. It makes the urine hypotonic. So basically, to summarize the situation, if I use ultrafiltration, I will remove more sodium compared to diuretics with the same amount of urine compared to ultrafiltrate. And as you know, sodium is the main culprit for extracellular fluid. Sodium is the main determinant. Next slide, please. Well, having come from the field of nephrology, I have to say that unfortunately, many of the concepts that we practice these days do not have a lot of support from randomized clinical trials. Ultrafiltration is an exception for me, at least. Ultrafiltration has had several randomized controlled trials, many of them very well done, that support its use. This table is a summary of those, and it is not inclusive. At least when you see SAFE started in 2003 in the US, but remember, there were several studies that were done in Italy before in US we start SAFE by University of California in San Diego, Dr. Jasky and his colleagues. Then there were other trials that were done. Unload in 2007 is a landmark, definitely, followed by Avoid Heart Failure in 2016. Both of them actually were done by Dr. Costanzo and her group. I have to say there are two studies between these two, 2007 to 2016. There are several studies, two of them probably more important. One is CARRESS 2012, that Dr. Costanzo will go through the details of it. And the other one is CORE trial, again from Italy, from Giancarlo Marenzi's group. But that one is pretty much the same results of other studies. It has a longer follow-up, but the protocols and the findings are pretty much the same. So basically, all these randomized controlled trials show that, number one, we can take more fluid from people with ultrafiltration compared to diuretics. Number two, it does not seem that this increased efficiency of fluid removal would be associated with an adverse impact on the kidneys, something that I, as a nephrologist, am very interested in. Next slide, please. Let me finish my talk with mentioning a point that many of you have in mind. You know, it is very well known that randomized controlled trials, as good as they are to provide data, reliable data for us, you always have in mind that these people, even the control group that has been in a randomized controlled trial, they're monitored so well for these trials that do they really reflect the real life experiences? You always wonder. So one study that has actually answered this question is this study. This is a real life scenario. It's a real world experience, a 10-year real world experience that was done in Abington Hospital in Pennsylvania. What they did was that they did more than 300 patients with acute decompensated heart failure. They used ultrafiltration for these patients. What did they find? On the left upper side, you will see the heart failure hospitalizations. Before they use ultrafiltration, these patients were coming to the hospital 2.1 times per year. But look at it when the patients received ultrafiltration. It went down from 2.1 to 0.4. 80% reduction in heart failure hospitalization. Actually, this is what the studies in Italy showed, and Unload also showed that you do one session of ultrafiltration today, for the next 90 days, the 3 months, the patient come to the hospital less often. Also, if you look at the bottom on the left side, you see that 12.4% of them only had rehospitalization at 1 month, which the national average is around 24%, twice. And fluid removal, just like I said for other studies, you know that when you are using ultrafiltration, not only you are more efficient, you can take as much fluid as you want, but it is predictable as opposed to diuretics. You give diuretic, then you wait to see what it generates. That's why we don't have a number. What's the exact dose that you should give to a patient? Every center, every study comes up with its own protocol. In ultrafiltration, it is predictable and adjustable. If you see that they are still congested, you can increase. If they are just not having a lot of congestion, you can cut down on the rate or the volume of extraction. With this, I finish my presentation and I ask Dr. Costanzo to talk about CARRESS heart failure trial that I'm sure there are a lot of very interesting points that she can share with us.
Thank you very much, Dr. Kazori. I would like to say that it has been an absolute pleasure to work with you for several years, and I am honored to have been able to write manuscripts together. It was not only wonderful, but also fun. And also today, even though I am a cardiologist, I'm wearing a pathologist hat, because what I would like to do is actually an anatomic dissection of the CARRESS trial. This trial is in many ways unprecedented because it brought to a screeching halt the adoption of ultrafiltration. And I still see, unfortunately, that many colleagues 8 years later continue to refer to the CARRESS trial as the trial that has demonstrated that ultrafiltration is not more effective than diuretics, and it has more adverse effects. And I would like to show you that not only this is not true, but that no conclusions can be drawn from this trial. Next slide. The CARRESS trial consisted of ultimately 188 patients only. The enrollment was extremely slow, and patients were randomized to two arms, an ultrafiltration arm and a stepped pharmacological therapy arm. If you look at the two columns, you can already see the disparity between the two groups. For the ultrafiltration patients, there was a one-size-fits-all 200 cc per hour of fluid removal. And should patient in this arm require other therapies, specifically vasoactive therapies, this was considered a failure of treatment. On the other hand, in the stepped pharmacological therapy arm, there was a very detailed diuretic protocol, including when to add other types of diuretics to the loop diuretics. And the inotropic agents were allowed as part of the pharmacologic therapy. Next slide. Another, and perhaps one of the major problem of the study was that it had a binary bivariate endpoint. In other words, changes in weight and changes in serum creatinine were considered simultaneously, and underlying the rationale for this primary endpoint was that an increase in serum creatinine is always detrimental, and that a weight loss is always a positive effect. Next. However, there is a very interesting study that actually was done from the dose trial. And as you know, in the dose trial, patients were randomized to either bolus diuretics or continuous infusion, and to standard diuretic dose versus high dose, meaning 2.5 times the oral dose received by the patients at home. And there was absolutely no difference in anything in the four groups. However, it was noted even in the main manuscript that patients on the high intensity arm had greater fluid loss, greater weight loss, and a slight and transient increase in serum creatinine. So Dr. Briscoe and colleagues analyzed those patients according to whether they had worsening renal function, defined as an increase in serum creatinine by more than 0.3 milligrams per deciliter, versus those that were unchanged or had actually an improvement in their renal function. And the two graphs that you see are incredibly telling, because what you see is that the patient that had, quote, worsening renal function had much higher survival, many fewer hospitalization, ER visits, and unexpected office visit than those patients that had been defined as having improved renal function. Why is this? This is, in my opinion, because patients who had improved renal function were the patients that had the least effective decongestion, and decongestion, residual decongestion, has been showed repeatedly over the year to be a negative prognostic indicator. Furthermore, an increase in serum creatinine does not mean worsening renal function, does not mean renal toxicity, is an expected consequence of the hemodynamic changes resulting from volume removal. Next slide. Actually, Dr. Kazori and I had the, I would say, the delightful experience of writing the editorial to a per protocol analysis of CARRESS, which was not published until nearly 6 years after the publication of the original results in 2012. Next slide. And interestingly, when you looked at the per protocol population, actually their findings were very similar to those of unload. Higher cumulative fluid loss, higher net fluid loss, more weight reduction, and the increase in serum creatinine without any differences in outcomes noted between the ultrafiltration and the pharmacological arms. But this is not the most important message of this manuscript. The most important part of this manuscript is that it laid bare the enormous limitations of the CARRESS trial. And I will try to go through them one by one in the next slide. First of all, on the right, you see the study flow diagram. And if you look carefully at the information from the flow diagrams, you will see, for example, that although many individuals felt that CARRESS had taught us how to use diuretics in acute heart failure patients, unfortunately, neither the diuretic treated patients nor the ultrafiltration treated patients in this study even remotely could be said to have been decongested. In fact, only 15% of the patients in the diuretic arm and 23% of the patients in the UF arm were judged by the principal investigator as having achieved optimal volume status. The other enormous discrepancy was that diuretic therapy was continued up to the 96 hours of evaluation of the primary endpoint in 80% of the standard care group, but only in 32% of the UF group. Obviously raising the question as to why the therapy was not continued to the time of evaluation of the primary endpoint. And I have to say that having used ultrafiltration since 2002, I have never seen the number of filter clotting seen in only in half of 188 patients of the CARRESS trial. And Dr. Kazori and I discussed at length why this might be. We didn't believe it was related to a low ultrafiltration rate because that actually would reduce filter clotting. So we concluded that the only possible explanation for so many filter clotting had to be related to an excessively low blood flow provided to the patients with the ultrafiltration device. But another very sad realization from this study is that in 28% of the patients, the only explanation for discontinuation of UF was called MD decision. And this was a separate category from what you see below, which included achievement of optimal value status, hypotension, hemodynamic instability, volume depletion, increased creatinine, filter clotting, or vascular access failure. I'm sorry to be so blunt, but when you exclude all these causes, MD decision can only be ascribed to unwillingness of the investigator to continue the therapy for unknown reasons. Next slide. Even more telling are the ultrafiltration rates that were achieved up to the evaluation of the primary endpoint. First of all, you will note that none of the patients in the ultrafiltration arm ever achieved the ultrafiltration rate that was mandated by the study itself. And this is bad enough. But what is even worse is that the investigator initiated ultrafiltration at an extremely low rate, 83, and then they increased the rate subsequently. Why is this so astoundingly bad? Next. It is bad because the reason ultrafiltration works is by recruiting the interstitial fluid into the vasculature at a rate which is called the plasma refill rate. The plasma refill rate drops as the volume status decreased. And the more the plasma refill rates drops, the more you have risk of intravascular volume depletion. What you want to do is depicted on the left, meaning that when you begin an individual on ultrafiltration, you either continue that rate or you decrease it over time. You do not increase it. So the CARRESS patients were in the situation on the right where fluid was removed at a rate higher than the plasma refill rate. So no wonder they may have had instances of intravascular volume depletion. Next. So instead, when ultrafiltration is used properly, this is what you see. This is a real patient of mine who actually had predominantly right ventricular failure. And because patients with right ventricular failure are highly preload sensitive, in those patients, we tend to use even lower UF rates than normal. And what you can see in this slide is that the gray is the fluid removed by ultrafiltration. But the important fact is that as the fluid is removed by ultrafiltration, the patient's urine output also improves. And this goes back to what Dr. Kazori said earlier. The reason you have an increased urine output is because you are decongesting the kidneys. You are reducing renal venous congestion and increasing GFR. And number two, you are giving the patient a diuretic holiday that perhaps allows a attenuation of the renal tubular adaptation to loop diuretics. Next. So this was my last slide, and I hope you will keep in mind that CARRESS was just a phase 2 trial, that unfortunately it was not conducted in a manner that was equitable between the two arms, and therefore our judgment on ultrafiltration should not be based on the results of CARRESS, but should rather be based on that of other randomized controlled trials. Thank you for your attention.
Well, thank you so very much, Dr. Costanzo, for this detailed and meticulous exploration of CARRESS heart failure trial. So with this background, it is time again to go back to real life experience, to a single center aquapheresis ultrafiltration experience that Dr. Jeffries is going to tell us about. Please.
Thank you, Mira, and thank you everyone for the opportunity to speak with you. So giving you a little bit of our local experience here at Tennessee, just as a background, I've been leveraging ultrafiltration for probably, I guess, 15 years now or so a long time. And we have a lot of historical experience that we'll talk about at the end as well, which will kind of tie some of the things that Maria and Amir sort of spoke about earlier. Next slide. So we really, I joined my current position about 3 years ago, and obviously familiar with the technology. So I felt that we really needed to bring aquapheresis, ultrafiltration into our healthcare system here in Tennessee. And it was really a nascent project. It was a completely new idea to the providers, to the infrastructure, definitely to the administration. And, back to, as you heard from Maria, is this idea that, well, we have data that shows that it's ineffective and it may actually hurt people. And it takes a fair amount of undoing and education to try and bring people to a contemporary understanding of ultrafiltration. So we really wanted to see, in our local experience, compared to existing data, which you've heard very thoughtful dissections, especially of CARRESS, and, looking back at AVOID, for example, what is the real world experience? And we all know from RCTs, those are biased populations inherently because they were selected to be in a research trial. They're typically seen at large centers. So those patients do not reflect the heterogeneity of the real world experience. And so, as you've heard a bit about prior, Abington has had a very impressive recent presentation regarding a decade's worth of utility and usage and safety. And so as a new program, we decided we were going to prospectively collect as much data as we could in sort of a deep phenotyping approach, if you will, simply to try and characterize the population and understand more about the changes that we expected to see. Next. So we performed a retrospective analysis. We had 30 patients at that time, and we recently presented these data at the ACC, and it was very well received. But this time period was from October of 19 to October of 20, so a year span. And we did all of our therapy using a FlexFlow system. And obviously we, in the real world, we don't pre-prescribe filtration rates such as, a 200 cc per hour. We tried to be informed based on, the clinical findings, the serologic data, those sorts of things. So it was an adjustable rate. And these were typically prescribed and managed either by a general cardiologist or someone else who's active and involved in our community hospital system, such as hospitalists. And so this comes back to, I hope an underpinning takeaway is that you don't have to be a heart failure provider to use this technology effectively. Next. So our data, we had a mean age of 62 years, almost 3/4 were male, a little over half were Caucasian, about 80% were HFrEF, and that gives you an idea that, 20% probably were HFpEF, and we've actually published data, and I think Maria alluded to this, in someone primarily right-sided heart failure, very preload dependent. Well, similarly, HFpEF populations are very preload dependent, and it's easy to over diurese them and get them into a low cardiac output state. So we had a diverse experience, but predominantly a systolic dysfunction cohort. About 1 in 10 received some sort of inotropic support. In the beginning, creatinine for these patients was about 1.8 and a mean GFR estimated of about 37. And what we tried to do with our process was pursue a right heart cath at the time of beginning ultrafiltration. And I think that makes a fair amount of sense. There are a lot of people that you see clinically that you may think are volume overloaded, but it turns out maybe their pressures don't support that. And so actually we found a couple of folks that actually did not warrant therapy, which is a good thing. Obviously you want to leverage the therapy appropriately, both utility and non-using when not needed. Next. So what we started out with was really having an idea of the goals for volume removal and what our duration was going to be. And we typically started relatively low, but we did dial things up as needed. And it's not because the patients wouldn't tolerate it, but remember, new technology in a system unfamiliar with the technology, you want to allow people to learn and do things in a way that they are going to understand how this works, and more importantly, document the safety of the therapy. And we were pretty aggressive in titration, which I think was very helpful. And as I said, we tried to pursue right heart catheterization, especially as we matured more in our program, which ultimately led, obviously, when they're in the cath lab, to using central access. And then we would typically do an empiric reduction of the ultrafiltration rate to about 100, 125 cc's per hour. But we felt like using a cardiac index was useful in planning our ultrafiltration strategy. And back to you heard from Dr. Costanzo about, you do really have to be mindful of the refill rate. Fluid's not going to get to the kidney if it's, not going to mobilize intravascularly, obviously. And you can't exceed that sort of dynamic. Otherwise, you will potentially induce kidney injury, which is something we want to avoid. Next slide. So pre-ultrafiltration, our patients were, and these are not dissimilar to some of the data you saw from Dr. Kazori, a little over 2 per year. And about 3/4 had an EF less than 40%, with an EF around 34. You heard about the about the inotropic support and what our starting renal function assessment was. And we really tried to leverage this in the face of what we thought was inadequate diuretic response, or what we would more appropriately term now, I think moving forward, is a diuretic resistant patient, and there are ways to assess that clinically. And the initiation of treatment was about 2 days from the admission. So what we saw was a reduction mean of about almost 10 liters, duration of about 70 hours. So it would have been near a 3-day experience, just as you've heard about. with a mean weight loss of about 16 pounds, ranging up to almost 35. And we saw really no remarkable change or anything important in creatinine. But as you've heard, that's really not a marker of kidney injury per se. And that's some of the things we've learned about that we haven't seen in this discussion today. But how can you use true acute kidney injury biomarkers to help guide this? And those are things that people have investigated. When we did sort of a subjective assessment, we had half at least saying they were moderately improved and a third saying they were markedly improved. That we did have one patient with a bleeding issue, but that patient had other comorbidities that really restricted any opportunity to control bleeding. And our mortality at 60 days was 13.3% and 20% at 90 days. Next. These are the parameters that we were assessing, and you can appreciate it's a lot of information, but I think what I hope everyone takes away is that, you know, comparatively, this is a technology that can be used safely and effectively in, you know, in smaller hospitals and hospitals that are not familiar with ultrafiltration, and demonstrate very similar results. Next. And these are our rehospitalization rates. And, you know, it's, I think, continuing, this is something we continue to collect data on. But I can tell you, we've had remarkable changes in our local data sets for readmission. This location of the country, you know, obviously a high prevalence of heart failure, diabetes, hypertension, coronary disease, and along with that, obviously non-compliance. So a lot of the things that we've been able to accomplish, I think, are remarkable and have a demonstrable effect in the community on readmissions and mortality. Next. And these are the mortality rates, and you can appreciate, you know, the one data point at 60 days that we had is about 13%, which is actually lower than reported in CARRESS or dose, given some of the limitations you've heard about, and a little bit higher at the 90 days compared to avoid. So we still have some opportunities for improvement, but remember, we have a pretty small cohort that we're reporting on here. Next. And so our what we did was, you know, these were our things that, so our outcomes, and you've seen these on the prior slides. What we did was we actually looked back at our patients serving as their own control, because it really is hard to compare this to a historical cohort that maybe is in Montreal. We need something local that we can look at. And you can see this, that our reduction in 60 days was 0.3, which was statistically significant. And we think that that's a pretty important marker, meaning that basically, as you heard from Dr. Kazori, you had a patient that was cyclical, right? They continued to live in this admit, diurese, ramp up profile, probably not euvolemic, discharge, bounce back, boom, boom, boom. And this is the kind of thing that we think we're able to disrupt with ultrafiltration. Next. And so for us, I think we found this to be hugely helpful. I think the things that you have not heard as much about, but I would argue that both Amir and Maria would agree, are the quality of life stories you hear from these patients. One of those patients that said that, you know, had a very significant benefit was a gentleman that told me he hadn't seen his feet in about 12 years, just because he was so congested all the time. And he was just so happy. And so remember, in heart failure, and we have people, you know, obviously on this, a lot of the endpoints we look at aren't meaningful to real life sometimes. And that's part of what we are talking about here. If I meet an endpoint for mortality, but I have an improved quality of life, one might wonder, is that really the best endpoint? And so some of the things we talk about are important for the FDA, for clinical trials, I get it. But really what we're trying to do is improve the lives of patients. And I think that that's what this technology accomplishes. Next. Thank you. I'll turn it back over to Dr. Kazori.
John, thank you very much for this interesting experience that you shared with all of us. I have to say it was impressive, and I have to add to your point about rehospitalization being important for patients in terms of quality of life. Also, it seems that the hospitalization rate for heart failure might be an independent risk factor for adverse outcomes. So basically, by bringing it down, you just kill two birds with one stone. That I wanted to add. And also, if I may add another point just to cover the practical aspects of ultrafiltration therapy, and you both, John and Maria Rosa, mentioned this in their presentation. You know, you have the option of starting ultrafiltration at any time during the admission to the hospital. But it appears that if you start earlier, you might get better benefit. You saw in Dr. Jeffrey's presentation, they started around 2 days. Most of these randomized trials started the randomization within 24 hours. So we need to keep that in mind. If you feel that the patient has had several admissions to the hospital, and you know that this is one of the main contributors to reduction of rehospitalization, you might consider it earlier than later during the course of admission. And the last practical aspect I wanted to mention is what, again, both Dr. Jeffries and Dr. Costanzo mentioned it in their presentation, the adjustable rate of ultrafiltration. This is just like another medicine. You just don't give 200 milliliter per hour and just tomorrow morning I will see how the patient does. The plasma refill rate is a very important concept in both nephrology and cardiology. We need to keep that in mind. And remember about the studies. Actually, if you think about it, it is very interesting. When CARRESS heart failure did ultrafiltration and didn't do the adjustable rate, they just did a flat rate. We had 4 years later, Maria Rosa did their study. They call it AUF, adjustable UF. They put it specifically adjustable ultrafiltration because of this specific point. I wanted to mention that. So now I think we can open the stage for the questions if there are any.
Sure. Thank you so much, all the speakers. This was a fantastic talk. So the first question comes probably to either Dr. Kazori or Dr. Costanzo. Was weight-adjusted serum creatinine ever calculated in the CARRESS study? So if you all knew that and could comment on that, please.
I can tell you no, it was not weight adjusted at all. No.
And if I may add, is that the increase in serum creatinine was 0.04.
Yes.
As much as it was statistically significant, I don't know if anybody will change his or her practice for the creatinine that goes up from 1.2 to 1.24.
Great, thank you. And this could be for any of the panelists, just in terms of a big question that comes up and has come up in the chat is how do you determine when diuretics are not adequate and when they're not working to switch? Because typically what happens, patients come in, they're overloaded, they give them diuretics, their creatinine starts to go up, they stop the diuretics, they might give them a little bit of fluid. Meanwhile, they've stopped all their other medicines and they do sort of this push me, pull you. So how do we determine in an expedited way about diuretic resistance?
Well, I do. One of the things that I learned from Dr. Kazori that is very easy. I check their urinary sodium concentration. And if that is low, especially if it's below, let's say 70, you know that that patient's natriuresis is compromised and the patient is not going to respond well to the diuretic. So you can hit the patient with as much diuretics as you want. And actually, if you do that, you see the urinary concentration of sodium going down.
I completely agree with Dr. Costanzo.
I agree. We've been doing something similar. And I think the other thing, that big pounding of diuretics, you continue to augment your neurohormonal profile, making things very difficult, right? So it's not favorable in any direction.
Great. Thank you for that. Also, could you talk a little bit about, and I'll direct this to Dr. Jeffries just for his most current study, just in terms of how we're picking out these patients, how we're determining who's right for this, and then maybe then Dr. Costanzo could comment just based on your expertise with all the randomized trials that you've done.
You know, what I would say is we've tried to be relatively agnostic. I think, you know, obviously you may not want to pursue the therapy in someone who's diuretic naive, but that's a pretty rare thing in most of our practices. So when we see people, I think I'm just trying to think about just some simple things. And, you know, in understanding the physiology behind Lasix or diuretics in general, we know that it's just not favorable. And the sort of resistance or tachyphylaxis that Amir referred to earlier. So we've really been thinking about it on the front end as much as possible, simply because it's the same question I ask everyone else, you know, in these panels is, okay, you give 200 of Lasix, how much is the patient going to urinate? Mm-hmm. And the smartest people in cardiology cannot answer that. So, but if I know what I'm trying to achieve, whether that's dry weight or whatever the case may be, I can prescribe this therapy to achieve that outcome. And to me, that seems like common sense. So I think something that maybe suppresses your neurohormonal activation, that I can actually decide how much fluid and how quickly I want to take it off. I get it. It's a little bit of work involved in getting people set up for this and starting it. But I think the benefits outweigh the downsides.
I completely agree with Dr. Jeffries. And one thing that I didn't have the opportunity to point out is that the CARRESS trial was a rescue trial. In fact, it was required for your renal function to worsen with previously given diuretics to be enrolled in the study. And so, as John said, unless the patient has been previously naive to diuretics, if I see a patient that is clinically fluid overloaded, that is the patient that I would consider for ultrafiltration. In both unload and avoid, we had specific clinical signs and symptoms. Patients had to have at least 2 signs and symptoms of congestion. We are now exploring more precise ways of determining the amount of fluid overload using blood volume analysis. I have some patients that currently have a implantable pulmonary artery sensor. So if we see their PA diastolic pressure rise well beyond what is our target, that is also helps to determine the extent of fluid overload. But as Dr. Kazori said, in my experience, the earlier you use it, the better, because you don't have neurohormonal activation revved up by previous diuretics.
Excellent. Thank you so much. This one I think is a great one for Dr. Kazori. This comes from one of our viewers. Cardiology has slowly adopted the UF therapy at the facility. However, nephrology remains vehemently, almost viciously opposed. Are there any pearls that you... I hear an opportunity for a phone call, perhaps.
That was really for me, this question. Yes, that I have to say that if you look at all these great trials, I have to say, unfortunately for us, They're all published in cardiology journals. The cardiologists have taken a lead on this. They know what they are doing, and they have been doing all these trials that are, again, many of our aspects in nephrology don't have that much of support, the academic and research support that ultrafiltration has for heart failure, these many randomized controlled trials. So I have to admit that some of us, the nephrologists, might not be fully aware of this. What we have in ultrafiltration for dialysis patients, for dialysis machines, is completely different from this concept. They just share the name. If you think about it, the concept of having such a low blood volume in the circuit with these dedicated devices of ultrafiltration, it's a game changer. The blood flow rates that are so low, we cannot even imagine this in hemodialysis. The lowest we go is 200, 300 milliliter per minute. Here we go to 50, 100, right? So it is very different. I think the long-term, hopefully, goal would be raising awareness. I would suggest that if they have these kind of interactions with nephrology teams, ask them to look at avoid heart failure trial. And again, unload trial, as much as it was done in 2007, remains one of the best done studies that the results are valid to this date.
Great. Thank you so much for that. I have another question that is asking about patients that are heart failure patients, and then they come in with sepsis and fluid overload. If any of you have some experience in treating those folks using ultrafiltration.
If I may add one point, I just recently did a webinar for congestion in sepsis and COVID-19, actually. I have to admit, one of the things that we nephrologists, again, might be a little bit behind with the literature is the impact of congestion on the overall aspects of the circle of the disease, the pathophysiologic mechanism that is under that. We tend to always think that taking fluid off the kidney, it is pre-renal AKI, it will give you this has changed, specifically in the field of critical care medicine. We have very well done studies that shows when you have a net positive balance on day 3 of admission to the ICU, you have worse outcomes.
Right.
That's the time that, first of all, you shouldn't let the patient get volume overloaded. Once you get there, it would be in your best interest, in the best interest of the patient, to remove that fluid. If it happens with diuretics, do it. If it doesn't happen, that many times it doesn't, go for alternative options, including ultrafiltration.
Agree.
Thank you. Well, we're at the top of the hour and finished with our questions. I didn't know if any of you had any closing comments or pearls of wisdom to leave us with.
For me, the history with ultrafiltration has been a great journey. I certainly don't want to compare myself with Galileo, but what always, since I was a little girl, and I read that Galileo said, and yet she moves, as he was being taken to prison for saying that the earth moved around the sun. And I want to say about ultrafiltration, and yet she works. And I would like people to understand that it works. So I have come to understand Galileo frustration much more.
Very well put. I think what I would say from my perspective, just given the fact that I do pediatric and adult heart failure, is that we've used this technology safely and effectively in 800-gram neonates up to people in their early 90s. And so there are very few technologies or drugs that we have access to in the United States currently that we can use that are relatively independent of age. And so keep this in mind as something that you may think you've already thrown the kitchen sink at them, but until you've leveraged this, I would argue you haven't done everything that you can. And thanks everyone for attending.
I think the nephrologist should have the last word.
Well, thank you very much. It was my distinct pleasure and honor for me to share the podium, the stage with two distinguished professors and internationally known experts. What I can say is that I'm hopeful that we nephrologists would follow the road. I think the ultrafiltration for heart failure has started a great, I would say, field, but I doubt that it would just stop here. When I think about the acute kidney injury after cardiac surgery or other settings that congestion plays a key role in determining the adverse outcomes, I think ultrafiltration has started with heart failure, but I doubt that it will stop there.
Great. Well, thank you so much to all the panelists and all the attendees. Again, this will be available on our YouTube channel, and we will sign off. Have a wonderful afternoon.
Thank you all.
Thank you.
Thank you.
Have a great evening.